Okay, first I would like to introduce Dr. Siv Sovannaroth. He is a Malaria Program Manager from CNM Phnom Penh, Cambodia, and he will give a talk on malaria epidemiology and antimalarial drug resistance in Cambodia. Okay, Dr. Siv, please. Siv, could you please unmute yourself?
Sorry. Thank you for everybody. I'm Dr. Siv from the National Malaria Control Program. I would like to present you the malaria epidemiology in brief in Cambodia and the history of the anti-drug resistant in Cambodia. Yes, you see from 2000, malaria case has been dropped out from more than 100,000 to only 4,000 right now in 2021. So this is a big success of the program that has been bring cases to the lowest cases in the country, and we don't have a malaria death since 2018, and now it's 4 years no one death due to malaria since 18. This is a big success of the control program, and we have a mandate to eliminate malaria by 25, and hopefully zero PF and make by 2023. This is the map of malaria epidemiology in Cambodia. Here you can see the right side is a PF in mix. You see in Cambodia right now, all districts have PF incident less than 1 per 1,000 population. It means that all the districts in Cambodia reach the pre-elimination status of PF malaria in the whole country. Except for PV and other species, we can see that they still have 9 districts still have the malaria incidence more than 1 and in the country. So but however, you can say that 91 of the districts of Cambodia have annual parasite incident less than 1, and except the 9 OD represent of 9% of the total of district in Cambodia will still have malaria incident more than 1. Talking about the history of drug policy change in Cambodia, you see since 2000 and from now, Cambodia used to known as epicenter of drug resistance, especially the artemisinin resistant and also multidrug resistant in Cambodia. And you can see the diagram here from 2000 to 2010. We use a loose tablet of artesunate mefloquine, and from 2010 to 14 we changed to DHA-PIP, and from 14 to 16 we use both DHA-PIP and artesunate mefloquine, but from 16 and until now we use artesunate mefloquine as a whole country. But along the way here we are not exactly resistance is not emerged in whole country. Mostly it start from the western part of the country. So that's why you can see that from 2000 to 2010 it's there is a emerge of artemisinin resistant, and we also artesunate mefloquine or artesunate lumefantrine have also failure in some area, especially in the western of Cambodia. And so in that middle of the period 2008, we have been started use DHA-PIP in pilot, but however, just only 1 year use the resistance with the DHA-PIP has been found, start to be found in pilot. So even that in the whole country is not during that time that difficulty to say that we are used the same drug of whole country. In our country we have used 2 different drugs because of some western part mostly start emerge resistant fastly than the other part of the country. So that's why in Cambodia during that time we has been used the DHA-PIP, we has been used Piramak, and we also have used Atovacon Proganil in particular one place in Thailand. But now start from 2016 we has been the use artisanal mefloquine because of artisanal mefloquine has been the susceptible back after the nearly 10-year resistance from 2000. But until now we don't have any problem with the drug resistance after we use the artisanal mefloquine. There is some publication just told you that from 11 to 16 there is evidence of the DHA-PIP has been failure in Cambodia, and from 16 to 17 we are, as I told you, when we are start to use artisanal mefloquine from 2016, but not whole country has been used the same time because of the resistance is not formally the same in the whole country. Mostly the western part is a big problem, and the other part of the country is not so problem. And the other thing is drug delivery is not coming to the countries the same time. So that's why we have choose nearly 1 year to split the drug before we can use SMQ as a whole country. So it means that we has been replaced drug by western part, and after that we replace drug in the middle part, and after that and whole country because the availability of drug in the country. Speaking of the drug resistance from before, I don't want to explain more because this will be our colleague will be explain more about what is the multi-drug resistance in Cambodia, as everybody knows so far. Just to give you the update of the outcome of our TS studies in 2019 of PF malaria. You see, we 2019 we have 5 sentinel site whole country, and including the western part and also the eastern part of the country, and we has been tested with artisanal mefloquine. So you can see that there is all of sentinel site, the RCPL mostly 100% except one province near Thai border. There is 2 has been failure has been noted, and the efficacy only 88%. So but there is nobody know why the two patient is not susceptible with the mefloquine. But however, the sample size in that study is not high enough, so we cannot make any conclusion on that. So we are continue to do in 2020 with the same area, but unluckily we cannot find any sample in the same area, so we cannot test for TS in that area, except the others 4 provinces still show the 100% RCPR of artisanal mefloquine. And the same time we also tested with artesunate pyroranidine, and also the food efficacy has been shown here. For vivax, we also test for vivax as well, and we see that the TA had been shown in 2020 that artesunate mefloquine and artesunate pyroranidine still work even with the PV in Cambodia. Now the country has been started at the beginning to use ACT to treat the PF and PV the whole country. But this just information to make sure that if we use the artesunate pyroranidine for vivax also work. And also last year also we test for artesunate pyroranidine with the falciparum also that still can work. Currently, Cambodia, even we use artesunate mefloquine in the whole country, but we has been used artesunate pyroranidine for children less than five, because the currently not artesunate mefloquine pediatric dose available. There's only pyroranidine pediatric dose available. So in our country currently we use two type of regimen, the pediatric dose artesunate pyramak, and the children and adult dose we use artesunate mefloquine. We don't want to use two type of drug in the country. But there is no available artesunate mefloquine pediatric dose in the market. We has been ordered Cipla 2 times, and they try to produce for us, but the problem is the quality test has been failed 2 times. So we have no choice to use a pyramak in the country right now. We also choose artesunate the pyroranidine pyramak as a second line treatment as well. In our new treatment guideline, if SMQ has been failure, instead of use quinine and tetracycline, we we can allow to use a pyramak for the second line treatment as well. I think that my presentation is not long enough, so I think thank you for everybody here. Thank you.
Well, I think your presentation was very thorough and very interesting, actually. So thank you very much, Dr. Siv. Could I ask a question about to Dr. Siv, in fact, about the options for Cambodia? Had you considered another idea that's been discussed quite a lot recently? Has been using triple artemisinin combination therapies. You know, using 2 partner drugs for artemisinin instead of 1. Did CNM consider that in Cambodia, and what was the thinking?
Yeah, thank you very much, Dr. Olivo. Currently, while the SMQ has been the full efficacy of a drug has been treatment in Cambodia, so the considering of a triple therapy still hang on. It means that we are not consider on that yet. But however, we are going to put this in the new treatment guideline as an option, whether the resistance has been happened, and we can have a choice to use that. The big problem of Cambodia right now, we launching the new approach of the last mile elimination by WHO strategy. There is including the TDA and also the chemoprophylaxis in the to the general population. So SMQ is a big concern of side effect when we apply to the general population, and now we also concerned that if we are talking about the triple therapy, and in terms of using the new strategy, TDA or others, IPTF, seem to be that whether there are big problem or the side effect will occur. Even the study has been shown that the side effect is not really high. It is similar to the not the triple. It's not different from the current ACT, but even that, but people still not happy with the current ACT that we have provide for the TDA or chemoprophylaxis to the general population. So that's why we are hesitate to thinking that whether we are talking about multi-drug combination therapy. But however, we has been agree to join with the moral team to access the acceptability study of marketing in terms of triple therapy, in that we has been proved that the efficacy is already there in Cambodia, and also can be avoid the resistance in Cambodia in the future. So hopefully that's we are, however, we also put an option on that. Thank you.
Great, thank you very much. And just to be clear for those who are not involved in this, TDA is targeted drug administration, correct?
Yes.
Okay. So basically, giving the drug as prophylaxis to a large number of people. Richard Pearson is asking, in a recent talk, I heard that since the failure of DHA-PIP, artemether lumefantrine is being used in Cambodia. Dr. Siv, can you confirm this is not the case, right?
No, AL has been the use in the pilot study for the forest grower that has been done nearly 2 years by the Richard Group. They use AL for the forest grower for chemoprophylaxis. But seems to be that the result is quite good, and also the acceptability of people also quite high. So so this is the study that had been shown.
Okay, thank you very much.